Hello, Internet, or at least the small slice of the Internet that is interested in psychotherapy research, and how and why psychotherapy works. So my name is Dr. Trevor Ahrendt. I'm a licensed clinical psychologist, and if you're like me and you're like many other therapists, you're very confident that psychotherapy does work. You've probably been to therapy, you've benefited from it, you know that you can do good work with some patients, and therapy is successful with some of them. But there are kind of several mysteries about psychotherapy that might loom either large or small in your mind depending on how much thought you give them. So why does psychotherapy work for some people and not for others? Why are therapists of very different styles and approaches effective? Why are different theoretical orientations, some of which are in conflict with each other, equally effective? What's going on here? And so this video is about the mysteries of psychotherapy revealed. We don't have the budget for graphics, so you're going to have to settle for spirit fingers from me. But I want to take some time to try to answer some of these questions from at least one point of view. So I'm part of a group called the Personalized Psychotherapy Institute, which is a group of clinicians and researchers that build off the work of something called the San Francisco Psychotherapy Research Group, which developed a theory called control mastery. Throwing a lot of jargon at you, don't worry, we got a whole mess of YouTube videos you can get lost in to catch up on. So Personalized Psychotherapy Institute, which the main goal of which is to answer the question, how and why does psychotherapy work? And more importantly, how do clinicians tailor their psychotherapy to each individual unique patient so that they can maximize the amount of success in therapy for each individual patient? Okay? So in essence, our goal is psychotherapy that works for everyone. So if this interests you, I'd highly recommend checking out other videos on our channel. We're going to have a whole rabbit hole that you can go down where you can really get lost in this theory if you're interested. And we also have a free ebook that you can sign up for, and it contains the 5 most valuable or best summary articles of the control mastery approach, so that if you're interested in it, you can read it, see if it's something that you want to pursue further or start to integrate into your clinical work. So let's get into some of these mysteries, okay? So these were things that vexed me when I was in graduate school and my training, and I just wondered, why aren't we addressing these more directly? We're practicing all these techniques, we're doing supervision about what we say in therapy, but why aren't we addressing some of these more fundamental ones? So for example, why is it that there are therapists with radically different temperaments and approaches that are successful as therapists? So, for example, I started my work in substance abuse, and in the substance abuse world, if you've ever worked in there, or even if you haven't, you know that there's kind of an archetype of a therapist in the substance abuse world. The bulldog. This is the type of therapist who doesn't take any crap. They hold boundaries super firmly. If you're 30 seconds late for session, they kick you out. They're constantly challenging patients. They have like maybe a gruff demeanor, very confrontational. And some of those therapists are extremely effective with some patients. You know, when I worked with a recovery clinic, there was one therapist like that. And at the graduation ceremony for folks, when they finished their recovery program, many of them would cite that therapist as the most helpful person they had ever met in their life. Okay, so that's a very distinct style of therapy. Very effective for some patients. Similarly, we all know therapists who are sort of the melty empathy therapists. You know, they just exude compassion. They just sit there radiating this intense warmth that just melts you or melts patients and dissolves everybody's defenses. And they're just like this sort of magical sun creature that are incredibly warm and nurturing for everyone. And that's extremely effective for some patients. But each of those styles is also terribly ineffective for some patients. Obviously, some patients respond to the bulldog therapist with this adversarial, really high conflict and then drop out. And then other patients respond to the like sort of empathy therapist as wishy-washy, you know, the sense of this person's really wishy-washy. I'm not really getting anything. They're just telling me my feelings. I don't really care about that. I know I feel bad. I need some help. I need to know what to do. So why is it that sometimes that style is really effective and sometimes it's not? Now, additionally, so you might say, well, it might have something to do with theoretical orientation, right? Therapists love theoretical orientations. We love them, especially if they're organized into some sort of acronym, and especially if the acronym is like clever and says another word that relates to the therapy style. That's just like catnip for us. And right now there are over 400 different types of therapies. Actually, that stat is a little old. That might be updated more recently. So there's probably more than 400 different types of therapies right now. all saying this is how therapy should be done, this is what psychopathology is, here's how you treat it, this is how patients get better. And some of those theories are, somewhat close together, like the behavioral theories, for example, DBT, ACT, CBT, they all kind of hang together in a theoretical place. Sort of psychodynamic relational ones kind of hang together in a theoretical place. But comparatively, they're actually very different. And then if you add in like some of the postmodern narrative therapies, or you add in the newer, this is like kind of the new kid on the block that everybody's especially excited about right now, the somatic therapies, some of these theoretical approaches not only recommend different interventions, but even disagree with each other on a level of what psychopathology is or what causes psychopathology. And not only that, like even on a philosophical level, if those of you are like kind of geeky enough like me to kind of get into the philosophical underpinnings of the theories, they actually disagree about the fundamental nature of reality. So how could it be the case that these theories that differ so wildly from each other about what to do with patients, what makes patients suffer, and even how the world operates essentially, how come all of those therapies are roughly equivalent in effectiveness? So many of you, or some of you, I'm not sure, but many of you might have heard of something called the dodo bird finding. So the dodo bird finding is this research outcome. They often in research will do these what they're called horse race studies. So we do CBT versus psychodynamics, or cage match, or CBT versus medication, or CBT plus medication versus this other thing, sort of cage match therapies. Research studies, and just try to see, well, which therapy is more effective than the other. And when you look at individual studies, sometimes you can see an edge for one theory or the other, one approach or the other. But when they do what's called meta-analyses, which are looking at dozens, if not hundreds of studies, looking at the outcomes of literally thousands or tens of thousands of patients across all sorts of settings, what they tend to find is that all psychological theories that have some research basis are roughly equivalent in outcome. They all basically work out the same. It's called the dodo bird finding because there was a race in Alice in Wonderland where the dodo bird was judging a race, and then they stopped paying attention, and then everybody was running, and the dodo bird just said, oh, everybody wins and you all get prizes, which is just essentially to say that all of this time and energy that psychological researchers put into looking at different theories and different techniques don't yield that much difference in outcome, if any at all. So what do we do with that exactly, right? So these are two mysteries now we've got. One, why are therapists of radically different temperament effective, even though they approach therapy differently? And why are different theoretical orientations that disagree so profoundly about the fundamentals of psychotherapy, psychopathology, and human healing and suffering even, why are they roughly equivalent? So it can't be just about one type of therapeutic approach. It can't be just about one sort of theory. It was a little confusing. And now, finally, and this is where I wrote my dissertation, so I try to get my money's worth out of that dang thing as much as I can. What about the DSM and diagnosis? Why is that actually not particularly a good guide for treatment? So if you get 100 therapists in a room and you try to get them to diagnose one patient, very often there's not great inter-rater reliability, meaning they don't necessarily arrive at the same diagnosis very well. That's not as true in other branches of medicine, although of course there's some disagreements about that. But psychotherapy's diagnostic system, the DSM, is particularly fudgy in trying to get a bunch of people to agree on a diagnosis. But even if you do get a bunch of people to agree on a diagnosis, we say, okay, these 10 therapists, we all agree that this patient is depressed. Now, if you ask those 10 therapists, why is this patient depressed? And then you ask them, what will make their depression better? You will get 100 different answers. And that's exactly for the reason that we just covered. The therapists have different styles naturally, and they have different theoretical orientations. And both of those things try to hypothesize about what causes psychological difficulties and what cures it. But unfortunately, those don't really come out in the research very well. We're actually not 100% sure what causes depression. It's extremely complex and highly individualized. And also, what cures depression or alleviates depression, it seems to be that there's actually a wide range of interventions and things that can be helpful in helping with depression. So what the DSM actually is, when you get down to the nitty-gritty of it, is what's called a folk taxonomy. meaning that it's an effective language for people in a certain community to communicate concepts to each other, but it doesn't really map to diseases in the same way that medicine does. Because in medicine, when you identify the symptom cluster, you can identify the disease, and that gives you, and that meaning when you identify a disease, that means it tells you you know what the cause is and you know what the cure is. That is not the case. That is not the case in psychotherapy. That's not the state of the field. So why is that the case? And additionally, for anybody who's tried to work within the DSM framework really diligently, there's a tremendous amount of symptom overlap. Tremendous amount. The symptom, these are subjective experiences largely that people are trying to describe to you. So the diagnostic categories get a lot fuzzy. In practice, what I think a lot of therapists wind up doing is relying on sort of just general symptom areas like, well, this seems depression-y, this seems anxiety-y, this seems trauma-y. And usually, of course, those things are all mixed together. And a lot of times in the research studies, people are trying to really delineate and separate out, like, well, if you have any anxiety symptoms, you can't be in our study about depression. But that's not how the real world operates, and that's not how the patients that we actually see really show up. And so finally, I think for a lot of folks who are clinicians like myself, I'm primarily a clinician, I sort of dabble in research, but folks who are primarily clinicians, I think most of us, when we consult with each other, people don't generally use the DSM so much. They might use it to communicate with each other, but then as far as a guide to treatment, that's when people move towards theoretical orientations. So what exactly is the deal here, right? This is all very confusing. So therapist attitude seems very different, but therapeutic approaches are very different. The DSM doesn't guide treatment particularly well. Now, for the final mystery of psychotherapy is, why are debates about therapy often so hopelessly confusing about how to practice? So, for example, boundaries, or what psychotherapists call boundaries, which is, when do we start on time? Do we start on time? Do we start late? How much disclosure does the therapist offer about their own life, etc.? There are wildly different ideas about how much of that is okay, and people have extremely strong opinions about it. Like, people can be almost offended if you suggest too much of a deviance from one of those norms. This is really, really confusing. And I think that all of us also relate to the idea of being, or having had the experience of being in a case conference with other therapists, where the discussion about the case kind of devolves into this very confusing conversation, or even almost not quite an argument, but sort of a debate or back and forth about this is correct and this isn't correct, or people get very associative thinking about things that the case reminds them of, or people get very prescriptive, like, well, these are the 3 interventions that we should do to cure this person's anxiety. And people can have a very hard time talking across theoretical orientations about what to do with a patient. If you have a CBT therapist who's hardcore and a hardcore psychodynamic therapist, you try to have them consult with each other, they can wind up speaking about wildly different things. But then if you put them in the room with a patient, they might actually do pretty similar stuff. And in fact, the research shows that the most effective therapists do very similar things with patients, even if when you ask them to talk about why they did what they did, they have very different reasoning. So what is the deal here? Because we do know that psychotherapy is in fact very, very effective. It's an extremely effective treatment for most people. It actually works relatively quickly for many people. Not all. Some people are obviously much longer term cases. But it is a very effective thing. And people also like therapy a lot. In fact, it's rated in the Consumer Satisfaction Survey as the second highest consumer ranked product behind Lexus. So, maybe someday we'll catch up to Lexus, but we might have a little ways to go there. But anyway, so what are we supposed to do with all of these really contradictory things? So enter control mastery theory as an idea to answer some of these questions and provide a unifying theory about how and why psychotherapy works. So what if there is a through line here that explains these apparent contradictions and confusing differences? So this is where the San Francisco Psychotherapy Group and the Personalized Psychotherapy Institute have been working for a long time to try to discover this. Okay? So the theory that was developed was something called control mastery. It's a little bit awkwardly named. It's based on the idea that people do have some control over the level of defenses or how tightly they're holding on to their old adaptations. They have some control over that based on how safe they feel in the world, When they feel safe, they no longer need their defenses and they can relax. And then mastery, which is the idea that people are inherently driven to master their environment, to be competent and effective in their environment and in pursuit of their goals. So it was based on this really, really compelling and relatable story, which was that the founder of the theory, Joe Weiss, was in a movie theater, and he was watching a dramatic movie, and there were lovers who were separated, I think during a war, and then they reunited. And they noticed that many people in the theater began to cry when the lovers were reunited. And he thought, well, that's interesting. Why do the tears come during the happy ending? Why don't people cry at the depths of their sorrow? That would seem to make more sense. When you're sad, you cry. When you're happy, why would you be so tearful? Why would the sadness or the tears of relief emerge there? This is such a relatable experience, right? We've all had this experience where, back in the day when we used to go to malls, pre-COVID and when malls existed, you'd go to a mall, you lose a toddler, you can't find them for a couple minutes, and you find them and go, oh my God, and you get so tearful and then maybe even angry too. Don't ever do that to me. Oh my God, I love you. I'm so sorry. I can't believe it. All the emotion comes up then. Or if you imagine much more dramatic example, imagine you're sort of shipwrecked and you're holding onto a piece of wood for dear life, and then you are trying to survive, and then you get to the shore, and then many people collapse and become very emotional, and then, oh my God, I almost died. I almost die. One last one is that, again, when we used to meet people at airports, that when people reunite at airports, there's often a lot of tearfulness and like, oh my God, this is, now the emotion comes out. And so from this simple observation grew a huge body of research looking into this. And there are other videos that will be much more detailed to explain this if you're interested in it. But essentially the takeaway is this, is that people need psychological safety in order to relax their defenses or old patterns. And when they feel psychologically safe, they can relax and relieve those things naturally. However, different people require different things in order to feel safe. And so different people require different things in order to feel safe in therapy. So essentially the job of the therapist is to discover what type of relationship and what types of approaches does this particular patient need to feel psychologically safe with me and in this experience, so that they can then feel that it's okay to relinquish their old patterns and beliefs and move into a new life or new patterns. And so it's a therapist's job to decode what ways of intervening or being with this patient or responding to them actually will help them feel safe. So in theory, that sounds great. I'm sure like a lot of people are like, oh, sure, that's on board. But let me give you an example to make this more specific. So let's take the example, little example of lateness in therapy, for example. Some theoretical orientations are very big on this. Lateness is always bad and must always be confronted, and you must always analyze it forever. And then other theories are much more lackadaisical about it. It's like, well, who cares? People are late sometimes. I'm late sometimes. Like, it doesn't matter. Therapists also have their own intuitive sense of that. Like, I'm a very on-time person, so I want my patients to be on time. I think being on time is good. Conversely, I don't care about being on time that much. I'm relaxed. I'm an easygoing person. So what if there was a much better way to think about lateness in therapy than either what you liked or what the theory said, but rather it was rooted in what does this patient need and how and why are they using psychotherapy to get to their goals in life? So let's imagine you have two patients. They're both late routinely. Okay? What do you do with that? Well, from a control master perspective, you don't know nearly enough about them to actually answer that question. So first things first, let's say the first patient is someone who grew up in a deeply perfectionistic household. They were constantly being criticized for not doing this, sit this way, have these nice manners, get these good grades, succeed, do all these great things, right? So they're very, very perfectionistic. And they start showing up late to therapy. From a control mastery perspective, you might have the hypothesis that they are testing out, is it okay for me to not be perfect? Is it okay that I'm not perfect and you'll still care about me and you will still value me? So with that patient, you might try to not care that much about being late, even if it sort of annoys you or you like being on time. But you go, okay, for this particular person, there is some value and utility in them being late potentially, because they are testing out, is it safe in the world for me to not be perfect? So you could not mention it, or you could even explicitly tell them like, hey, I noticed you're late. I don't think it's that big of a deal. You work really hard. This is your time. I trust that you're going to show up when you need to. I'm not worried about it. We're going to do good work while you're here. Okay? So that would be one idea. how to approach it with them. Now imagine that we have a different patient who grew up in an extremely neglectful household. Their parents were, or caregivers were, not particularly tuned into them. They didn't impose hardly any rules or discipline. They let the patient kind of run wild. The patient got in a lot of trouble. It caused a lot of problems in their life. They dropped out of school because no one was really paying attention. And now they're trying to get their life together and their life's pretty disorganized. And they start showing up late. Well, they might be doing that for a completely different reason. They might be wondering, does this person care enough about me and see enough potential in me to encourage me to work harder or be a little more disciplined? And so with that person, you might take the approach of saying, listen, I really think you've got a lot of potential. I think you and I can do tremendous work together, but we can't do that work if you're showing up late because we're just shaving off too much time. And frankly, you're paying me for time you're not spending, so I kind of feel bad about that. Like, I want you to show up and work so we can really get to what you want. So with that patient, you would take a much more active, strong hold of boundaries as a way of communicating to them, you don't have to live in a world and live a life where you don't live up to your own potential. So that's just a really small example. So if you're interested and intrigued by that, I really, really suggest that you check out our other videos. Control Mastery is essentially a meta theory trying to explain why other psychological theories are effective and why psychotherapy works and why it doesn't. It's not a specific set of techniques, so it's not like a do A, B, and C. It's more about how to be with patients rather than what to do specifically, although at times it will have some strong opinions about what to do. But the more of an overarching idea is, how should I generally be with this patient so that they can reach their goals? Control Mastery is also permission to be flexible. You can be very into CBT or very into psychodynamic or very into somatic therapy, and you can practice within a Control Mastery framework. In fact, much of the research on Control Mastery to determine its hypotheses have been done on therapists who don't know what Control Mastery is. That's really unique in the therapy world. Usually when they research something, it's like, we're going to research CBT, we teach everybody CBT, they know they're going to do CBT, they do CBT, we see if it worked. This one, we're going to look at a dozen therapists practicing, and based on their transcripts, we're going to try to predict who is going to be successful and who's not and why. And those therapists are practicing from very different theoretical approaches. That's super unique and to me lends a lot of credence to the underlying theory. So if you're interested in learning more, please come down the YouTube rabbit hole with us. We're going to post videos, I believe, every Sunday, so once a week. And again, if you're interested, you can check out our free ebook, which contains the 5 theoretical articles that we think are the best way to get started learning about Control Mastery. And if you're intrigued from there, we host online trainings that are very affordable and offer CEs for therapists for developing continuing education. And we even have free case conferences for members in the group. So please come check us out. And if you're interested, stay tuned. Thank you very much.